We're going to go ahead and get started so we can get to our presentation today. My name's Kate, and I'm just going to do a few introductory things before I turn things over to our presenters for today's webinar, Enhancing Adolescent Well Visits, Getting Them In, Setting the Stage, and Implementing Strength and Risk Screening Tools. We definitely want to hear questions from everybody, but there are nearly 50 people on the line and growing, so everybody is on mute for the webinar today. Please feel free to send your questions through the GoToWebinar questions pane as they come up. That'll allow me to organize them and have them ready to go when we get to Q&A time. We do have time set aside to take your questions, and we can follow up after the webinar if there are outstanding questions that we haven't answered. The one question I can anticipate is that, yes, the webinar slides and a recording of the webinar will be available on the Institute website today. And everyone registered should get an email linking to that later today or tomorrow. So this webinar is hosted through the Patient-Centered Primary Care Institute, which is a partnership launched in 2012 with the support of the Oregon Health Authority and managed by Oregon Healthcare Quality Corporation. We partner with experts to get primary care practices the technical assistance they need as they work towards the patient-centered primary care home or medical home model of care. We encourage you to visit our website, which is pcpci.org, to access resources like this webinar and other webinars that we have hosted to date. You can also sign up for our email list, which is how we announce future webinars and other training opportunities. Like I said, the Institute aims to help primary care practices achieve recognition as a primary care home through the state of Oregon's PCPCH program. The model is a set of standards organized under 6 core attributes, which you see here, and you can visit the PCPCH program website at primarycarehome.oregon.gov to learn more. We have some wonderful presenters on the webinar today. I want to welcome Colleen Rulin, Dr. R.J. Gillespie, and Kristen Case to share some excellent information with you. Colleen is the director of the Oregon Pediatric Improvement Partnership and instructor in the Department of Pediatrics at OHSU. She has over 16 years of experience working with primary care practices and health systems to improve the quality of care provided to children and adolescents. As a key component of her work, has been focused on adolescent preventive services and implementation of Bright Futures recommendations. And I'm going to go ahead and turn things over to Colleen.
Good morning, everyone. I'm really excited to be here and really honored to be co-presenting with RJ and Kristen about how do we improve the access and content of adolescent well visits. Okay. So in terms of the goals for the webinar, we have 3. I'm going to start off first just giving a basic primer of when I talk about an adolescent well visit, what do I mean? And what's supposed to be happening in adolescent well visits, and what are some of the strategies that we're going to be trying to address. And then we're really going to focus on specific tools and strategies that we've helped practices and learned from practices on how to improve adolescent well visits. And the way that we've structured this webinar is to focus on 3 strategies. One is how do you get them in for well visits. 2 is how do you set the stage for a successful well visit and for developing the adolescent as a healthcare consumer. And then 3, how do you implement broad strength and risk-based screening? So what we're going to do is provide tools and strategies for each of those 3 areas. And then thankfully, RJ and Kristen are going to provide the most interesting part of this webinar, which is how do you actually do it in the real world, and what are some examples that they've gathered. We intentionally chose 2 different types of providers to give you a breadth of experience. So RJ is a pediatrician that's from the Children's Clinic, which is a large practice located in the Portland metropolitan region. And Kristen is the clinical lead provider for the Multnomah County Health Department School-Based Health Center program. So you'll get a nice sharing from 2 really different places in terms of how do you implement these kinds of strategies. So this is the Bright Futures recommendation summary of adolescent well visits. So as you can see, there's a lot that's meant to happen in the adolescent well visits. And the periodicity for adolescent well visits is every year, which thankfully through the ACA is going to be something that's covered and something that's expected. As you'll see at the top, there's kind of the classic things that you would expect in a well visit, such as height and weight measurement, BMI calculations. But one of the really important parts, and one of the things we're going to be focusing on in terms of how do you operationalize it in practice, is really related to some of the screening and assessments and some of the anticipatory guidance. You know, one of the things we've been working on with practices is as they kind of try to figure out how do they improve adolescent well visits, it's really important to share with them how the work at a practice level to improve this area is really synergistic with a number of important state priorities and incentive metrics that are both within the coordinated care organizations here in Oregon and also within the patient-centered primary care home program. So for example, as you saw on the slide before, mental and behavioral health screening is a really important aspect of the Bright Futures recommendations. It's also a component of the PCPCH standards, and it's a component of the CCO incentive metric screening. And part of the reason why that area is probably synergistically highlighted in these different areas is if there's a need. So one of the great things that we've kind of highlighted in some of the memos that you'll see a little bit later is that when we're talking about mental and behavioral health, for example, 27% of adolescents in Oregon were at risk for depression. So these adolescent well visits are really an important opportunity to identify some of the risk factors that are going to be predictive of lifelong health. Another really important component of the adolescent well visit is actually developing that adolescent as a healthcare consumer. One of the great websites that I would recommend anyone to look at is gottransition.org. And what it is it focuses on how do we start to transition that adolescent to be the primary patient and transition that family to being support networks for the adolescent. Originally, this kind of concept of healthcare transition was developed for adolescents with special healthcare needs so that they could develop self-management and healthcare consumerism strengths. But what they found is that these are things that all of us need to have. If we're going to be good healthcare consumers as adults, it needs to be a longitudinal and intentional process. And that way of doing that longitudinal intentional process is through the rubric of the adolescent well visit and through periodic adolescent well visits, so that you're addressing these issues over time in a way that's adolescent and family-centered. So on the call today, we're really going to focus on practice-based strategies, but I wanted to just pause and say that there's a lot of reasons that adolescent well visit rates are low, and there's a lot of valid reasons why the things that are meant to happen in adolescent well visits don't happen. And so one of the things I would just direct you to is we've worked in partnership with the Oregon Pediatric Improvement Partnership Partners and with the Oregon Health Authority Adolescent Division on some important memos that just kind of lay out the framework and lay out some of the issues. So one, why are adolescent well visits important? Two, what are strategies needed? And in the strategies, we really focus on health system level strategies, policy level strategies, and practice level strategies. And again, this call is really focused on those practice level strategies. Secondly, there's just a lot of issues related to measurement of what happens. So again, we're going to be talking a lot about the content and how do you operationalize specific risk screening and strength-based screening into practice. But there is a number of really important issues to consider when you're trying to measure whether those things happened. And it's particularly important to note given that the new CCO incentive metrics incorporate depression and expert screening for adolescents. So I just direct you to those memos since we won't be covering them in detail, but they provide a good summary of some of the issues that we've identified. Okay, so let's get to the meat of this. So enhancing adolescent well visits. As I mentioned, we're going to focus on these three important strategies. So let's dive in. How do you get them in? So the three big strategies about how do we get them in that we're going to focus on is one, when they're in for other things, strategize on how to make that a well visit. Two, target adolescents through community-based approaches. And three, probably the most important one, is we do still need to enhance adolescent and parent understanding about why adolescent well visits are important. If the audience doesn't know that it's important, it's going to be an uphill battle to get them in. So let's start with that first one. One of the strategies that a number of our practices have been using is when adolescents are in for other things, figure out if you can make it a well visit. Obviously, not all visits is this possible. If a kid has a concussion, probably not a good idea to make that a well visit. But there are a number of kinds of visits that you could convert to a well visit. So you have them there, catch them. The other is that, a lot of adolescents that play sports need sports physicals. And so a number of the practices we've been working with have decided to just make a unilateral policy to not offer sports physicals. So when a family calls for a sports physical, the practice says, great, we'll be sure to fill that out. We try to do that in the context of a broader well visit that's going to address your child's health and allow us to talk about some broader topics that are important. The second is if the adolescent comes in for a medication or for some other type of visit, to at that time schedule the visit. So you have them there, you can't convert it to a well visit, but use the opportunity to schedule the visit so that you can get them back in. The second strategy is really to think about where do adolescents park their cars and how do you partner with them. And again, you know, we have Kristen from school-based health centers. That's a wonderful partner to consider as a private practice because, again, adolescents are there. They're at schools, and how could you partner with them to maximize access to well visits? And then the third strategy is that we really need to kind of start developing and disseminating adolescent materials and parent materials about why well visits are important. I know for many of us, we didn't experience what is recommended now, and so we need to make sure that we're being explicit about that. In addition, as I mentioned, Bright Futures recommends that adolescent well visits happen every year, and for many payers that didn't happen before, that was covered, and now it should be. And so there's a really important avenue of work that we need to do about how do we explain to adolescents what is going to happen at the visit, what they can expect, and what they can get from their provider. Okay, so let's hear from the front line. RJ, why don't you share with us a little bit about your strategies for getting adolescents in?
Good morning, everybody. So the first thing that I just want to throw out is that before ACA, most of the health plans in our area only covered well visits every other year at best. And so one of the things that we've really had to focus on is a culture change for patients and families and really explain to them why the change had happened, that annual visits had always been recommended, but they weren't covered by health plans. And really that it's a benefit that families should be using. And so we've spent a lot of time explaining that particular aspect to our families because most of them are still in the habit of coming in every other year. And so it's been a little bit of a change and a little bit of difficult for us to actually get that change to happen. As Colleen mentioned, we're one of the practices that don't offer sports physicals in our office. We only offer well visits. And from a practical perspective, you know, I see sports physicals as do all your joints work and is your heart working and can you physically get around to playing sports, whereas well visits really focus on a lot of the risk-based screening and the larger health issues. It doesn't take any more scheduling time to do the difference. In fact, you know, we do 20-minute well visits for the most part. And so we have some tools built in that we'll talk about in a little bit about to address the risk screening, but we just, as a policy, don't offer sports physicals in our office, only well visits. We've been looking at 2 different recall processes in our office and working first with internally, looking at patients who have not been in for over a year and generating lists and sending out letters to say, okay, it's time for you to come in for your physical exam. And then we also have partnered with our alert system, which is our statewide immunization registry. And the primary goal of that, obviously, is to improve adolescent immunization rates, but it has the secondary effect of getting kids in for well visits. And so we've been sending out letters to those patients who are missing their Tdap, Menactor, or HPV vaccines, and just telling them, you know, you need to schedule a well visit. You know, we do shot-only visits for patients who are up to date on their well visits, but generally speaking, if you're behind on vaccinations, we check to see if you've had a well visit recently, and if not, then we schedule that instead of a shot visit. We also try to do a lot of point-of-care reminders, so when patients are in for ill visits, or if patients or parents are requesting forms for school or for camp or for sports, that's one of the opportunities for us to review to make sure that they are up to date on their well visits. And, you know, if they are up to date, then we still give them a reminder, okay, so, you know, it's September, I can fill out your form, but you're due in December for your well visits, so make sure you get that on the books. And we also do that during, you know, medication refill requests, particularly for asthma and ADHD patients, because we want to see those kids, you know, once or twice a year at least. ADHD we see twice a year. Asthma we want to see them at least once a year as well. So when we get those medication refills, we make sure that they are up to date on their well visits. And we're going to talk a little bit about our transition policy over the next couple of sections, but I think that the transition policy that we have developed in our office, which is based on the information on that gottransition.org website, really is a way of advertising to families that there are specific tasks that need to be completed between the ages of 12 and 18 to prepare adolescents to become appropriate consumers of healthcare and to really take responsibility for their healthcare. And so the transition policy has actually helped us to frame a little bit of the value of well visits and part of what we're trying to accomplish during the teen years. So with that, I'll pass it to Kristen.
Hi, everyone. I think the first thing, okay, let's see if I can enter. I'm having a hard time changing the slide, you guys.
Just try clicking one more time on the slide.
Yep, I'm there.
Oh, do you want me to try it?
Yeah, why don't you go ahead and move it. So I think the first thing I want to say is I work in a school-based health center, but I'm a bigger part of Multnomah County Health Department. And so we have school-based health centers, and we also have our colleagues in primary care who are family practice, pediatricians, internal med. And one of the things I continue to be struck by is not only do we need to be educating our families and our clients, but we need to be educating our colleagues. I'm trying to support our primary care providers and trying to increase their numbers of adolescent wellness visits. And I'm continuing to get questions about when did it change to once a year? Is the billing there? So I think one of the important things is we need to continue to educate everybody around us and not just our families and clients. That said, I am in a different setting. I'm in a school-based health center where actually the access is right there, and so we are right where the kids are. The kids can come in and schedule their own appointments. We have a combination of walk-in, and we protect 50% of our slots for same-day availability, so when a kid needs us, we're there, and that's actually really important in adolescence because sometimes you have one shot with getting a kid engaged, and it's kind of like their agenda. If you're not there for that day they need something, they're probably going to go someplace else, at least in our world. And so it's really important that we are there when the kid needs us. And so that same-day access is super important for us. We also kind of buck up, and during the times of sports physical times, and then the other time that we actually get hit because we're in the schools is immunization exclusion time. So those are really big times for us to be there and to be able to meet the needs, because that's how we start to build a relationship with the kid and the families. I'm also about utilizing episodic visits. I think if we don't, I think we lose the opportunity. So that same-day access to episodic visits, like I said, is building the relationship. And then frequently, we actually at the beginning of the day, and I'll talk about this later, really huddle about our visits, and we look ahead of time to see what, as the kids are scheduled to come back in for asthma or ADHD or contraceptive care, it's like who needs their wellness visit, who needs immunizations, and really trying to sometimes actually turn those episodic visits into wellness visits. I think what I have found is when we tell kids to come back for their wellness visit, unless I can put some agenda back to them, it's like there's another reason for you to come back other than your wellness visit. We get more no-shows with those types of visits, so really building in their agenda as to how we can meet those needs when they come back. We have a slightly different world in school-based. Sometimes kids will access without their parent knowing, or that the parent's not involved in that if they're 15 and over. So one of the things that I think in school-based is our challenge is how do we assure confidentiality but try to bring the parent in those wellness visits. I'm a big proponent of, I don't think you should be doing a wellness visit with an adolescent without some level of engagement from the family. So really trying to work with kids about, we won't talk to your mom about birth control, but I know you need shots. I can see you need shots, and this is a really important thing that we need to get your parent involved in. So really trying to get parents involved even when the kids are coming in or the youth are coming in for confidential visits. So for us, it's like I have my MA contacting the family when the kid's okay, saying, Susie's due for a wellness visit. Can we do it today, or can she come back? So really getting parents involved as much as possible. And then the other opportunity we have is really doing outreach to schools. We've just hired a health educator, so more around social media with families and kids and youth around the importance of wellness visits.
Thanks, Kristen. All right, so let's move to the second step. So you got them in. Now how do you set the stage for a successful well visit and for developing the adolescent as a healthcare consumer? So there are three important factors that we would suggest you consider. And the first is intentional, explicit, repeated, and empowering messaging that you are transitioning the adolescent to being the primary patient. The second is to address confidentiality. And the third is to ensure that there is private time, meaning the adolescent is one-on-one without the parent, with the provider. So for that first one, transitioning the adolescent to be the primary patient, again, Bright Futures recommends that starts at 12, and again, it's a longitudinal process, and that you create an office-based policy for transition that explains what the policy is, why you're transitioning the adolescent to be the primary patient. One of the things you're going to hear from both RJ and Kristen is the really important part of framing the conversations and explaining why you're doing it, and making it normative and making it part of the natural process, rather than waiting until there's something more episodic and more problematic that then you bring it up. The really important part of transitioning the adolescent to being the primary patient is to start small. So asking the adolescent first if they have questions rather than the family. Encouraging the adolescent to call the office themselves when they're sick, so that you're starting to give them little pieces of success and little experiences before it's an episodic issue. And again, gottransition.org has great resources for practices about how would you start to implement this and what kinds of things could you talk about at each of the visits. In terms of confidential and private visits, it's really important that you define the visit structure for parents. So to explain to them what's going to happen, why it's going to happen, and that it's something that's really routine for all patients, not something that's specific to their child. So explain to the parents that they'll be asked to leave the room, but that the visit will conclude with the parents back in the room is a strategy that a lot of our practices have used to kind of make that one-on-one private time feel safe. The second is to really clearly explain confidentiality rules for adolescents. Explain what you won't share, explain what you might need to share, and do it in a way that kind of meets the adolescent where they are in terms of their understanding. One of the things that we had found from the Adolescent Health Initiative that our partners in the Oregon Health Authority Adolescent Division created for us is really these handouts that practices can use that are directed to teens. So this is the teen handout that really explain what I just talked about. What are you going to expect in terms of at the visit, and what are some of the issues related to privacy and confidentiality? And then another handout is one for the parent. So as a parent, what's going to happen at that visit, and what are things that they can expect? And again, some of the issues related to privacy and confidentiality. I know for the practices we've been working with, having something tangible and something that they can give to the adolescent and give to the family has been a really great way to be able to start the conversation, but to also have the documents for people to kind of absorb and read through after the visit. Some great resources additionally for you are on these two websites. I would encourage you to go explore them. They have some great handouts and great tools that practices can use on the front end. So RJ, tell me a little bit about how you guys set the stage for adolescents.
Well, I think that one of the primary things is really about how you frame the reason that you're asking the parent to leave the room. And I know that a lot of the conversation that we have when parents are out of the room really is the sex, drugs, and rock and roll. But I do spend a lot of time talking about transition and the growing responsibility of adolescents. And I frame that part of the reason for moving to this model where teenagers are with me independently is so that I can assess their healthcare skills and make some decisions about where they need to focus on in terms of that growing responsibility. I do refer to my confidentiality conversations as conditional confidentiality, which is what Colleen was alluding to, that you know, we keep most things private, but the way I phrase it is that if the teen and I come across something that we need to get help for, we're going to talk about who we tell and how we do that. And so I think that it's important to explain confidentiality, but also kind of remember that there is a loophole that we may need to get help for something that we'll have to share the information. And in those cases, again, I tell the teenager how I'm going to do that kind of disclosure. We usually start the process of transition at age 12. And really the idea there is to give a roadmap of what's going to happen over the next couple of years. And so we explain confidentiality and privacy. We explain the adult model of care. And really I talk about, okay, so to the teenager, here are all the things that your parents are doing for you right now that you're going to have to take responsibility for when you turn 18. And so some of those things are kind of age-based in terms of what I expect kids to know, like knowing the names of their medications, the doses and why they're taking things, the allergies that they might have. I ask them that they should be thinking about questions for their well visits. They need to know how to call advice nurses. They need to know how to make appointments and navigate our phone tree. And then they need to know how to obtain refills. And then I explained to the parents and the patients that after age 14, part of the visit is just between the teen and I. One of the AAP policies that is a little, I guess, confusing or frustrating on that is that when you get to the private exams, you still have to offer a chaperone, which is a little bit conflicting. Most of the teenagers, though, say that they don't really want an audience, so that hasn't been a huge barrier in my experience. And throughout that conversation about transition, I think it's really important to explain both to the teenager and to the parent that their parent is still always going to be a resource for them, and their parent should always be the first person that they ask if they have problems or if they have questions about their body or whatever, and that I'm a resource to back that up. But I want to always frame that the transition is not about cutting parents out or excluding parents from the process, and that the teenagers should always work towards developing a trusting relationship with their parents as well. So it's not exactly like you're kicked out and you're done. We've created a visual version of the policy statement for transition that I'll show you in just a second. And then we've also provided a lot of resources for our providers. And one of the handouts that we got from the transition website is called Performing an Atraumatic Parentectomy, which we really like in terms of some tips about how to gracefully have the parent leave the room, again, after that age of 14 for part of the visit. This is our visual version of our transition policy, and it just sort of talks about the steps of what's going to happen starting, again, between 12 and 14, and really with a goal of having kids transition to an adult model of care by the time they're 18, and then transitioning them to an adult provider somewhere between 20 and 22. Our providers always have a little bit of debate on that one, but generally in those end of college kind of years, then we're getting ready to transition them to an adult provider. Within our electronic medical record, and I do come from a big practice, so I have a person in my office who is able to program our forms for our EMR, and so it's a little bit of a, I guess, sore point for some practices that they don't have this ability. But we actually put into our anticipatory guidance sections some decision support reminders about what parts of the adolescent transition are supposed to be happening at each visit. And so for the 14 to 18-year-olds, this is where if kids have special health care needs, for example, where then we're starting to write out individualized transition plans. And if kids have intellectual disabilities, then we need to start talking to parents about guardianship and power of attorney and things like that. If the children are not able to developmentally take full responsibility for their health care, then they need to get some legal help on that part. But just to give you an idea that each of our well visits from 12 and up will have some of those decision supports built into the electronic medical record to help the providers to remember what they're supposed to be talking about. And back to Kristen.
Okay, I need help again. Sorry. Moving it to the next slide. I think I wanted to start with, I'm struck by, I actually oversee 12, 13 sites, and when I would look across the different sites, everybody was doing things differently. So one of the things that I moved forward with our program is trying to figure out a team approach to setting up a workflow that really was concise and consistent and standardized around these really core issues. And I'm working with primary care for the same thing, because we actually still, even in school-based, have 20-minute visits, and so there is a lot to cover. And one of the things I know really well is that providers can't do everything. So we have set up a workflow to really incorporate other team members to help with this work and actually to build a relationship with other team members. So one of the things we have set up, we've really standardized, is at a certain age, we bring the kid back alone. The parent stays in the waiting room, and then we invite the parent in at the end. And so then the MA will bring the client back and review the confidentiality with them, because we have a form that we'll go through that asks a lot of questions that are kind of red flags potentially around reporting. So we make sure that confidentiality is reviewed before any of those forms are filled out. So we have at the very beginning, the first visit when a kid is 14 and older, when they come in, no matter what they come in for, if it's a sore throat or a sports injury or a birth control start, we actually have confidentiality reviewed starting at 14 on up, and this is paperwork that the parent sees as well. And then we actually also make sure we review it annually, because one of the things I think we all know is for a 13, 14-year-old, they're kind of not even getting, why would I not involve my parent in this? By the time they're 16 or 17, oh yeah, they get it. And they may have forgotten the whole privacy issue that we actually hold, pretty true to our practices. So we're reminding them on a regular basis as they go through adolescence has been really critical for us. The other thing is really when we have our written questionnaire, asking the least threatening questions initially. It's, the whole motivational interviewing skill model is something I really embrace. And so how do we actually engage kids in the visit? And then figuring out as far as how we will involve the parent in what level of discussion. So if I have the kid first and then I'm going to bring the parent in, or sometimes I don't have the parent with me, I will go ahead and contact the parent by phone, and it's like, what part of this visit can we involve your parent in? We need to engage the parent. It's really important and critical to engage the parent, but what does that look like? You know, I don't need to tell them anything about birth control. If you tell me you're going to hurt yourself, we need to involve the parent. Or, you know, or if it's pretty benign, it's like, let's just talk to your mom about the shots that you need to get. So really starting to give the youth control over their visits and what they can keep private. The other thing that I continue to be struck by, because I'm in a school-based health center and kids come to me and they all, you know, a lot of them have outside providers, is they view their pediatrician or their pediatric provider as not, as this is somebody my mom takes me into, and I don't feel like I have privacy or confidentiality. So there's this perception with kids, and it could be us, it could be Kaiser, it could be whoever, but they view it, even though we know that our colleagues out there are providing confidential services. So it's really important that we continue to reiterate with kids, it's not too frequently that we do this. We really need to talk about privacy with kids. So anyway, that's all for that slide. Go ahead and go to the next. So one of the things that we actually have created is a lot of visuals for kids. So we have, this is a not so pretty sign because I couldn't print it. But anyway, this is a sign we have on every exam room, out in the waiting room. And one of the things I frame is, I think confidentiality, you know, maybe about 50–60% of the kids understand what confidentiality is. Privacy they all get. So I don't use the word confidentiality. I use the word privacy to really make them, you know, help them understand what they're doing. I mean, what privacy is and what we can keep private. Go ahead and go to the next one. The other thing that we did is we created a form, and I'll tell you, it's really hard to go down in word level. We actually had a form that I think this is 6th grade level or 7th grade level, but we tried to keep it as simple as possible for reading levels, and we have this in all the multiple languages. But this is something that actually is in the packets for the kids and the parents to see, and this is what we review when they come in initially. And we actually don't just have them read it. I have the MA actually go through it in a different way to make sure they really understand confidentiality.
Thanks,
and that's
Kristen.
it. Mm-hmm.
Okay, so the third and last strategy. How do you implement broad strength and risk-based screening? So again, at the beginning of the presentation, I shared with you all the things that are meant to happen at the adolescent well visit. And so one strategy that a number of our practices have used is to kind of use a global risk and strength-based screening tool that addresses all those key components in one form. And so, again, one of the really important things that you heard both in RJ and Kristen's presentation is the value of using a strength-based approach. So if you just focus on sex, drugs, and rock and roll, you may not have some of that trust, and you may not identify some of the strengths that are really going to help that adolescent be able to push through some of the risks that they may be experiencing. In all of the risk-based or strength and risk-based screening tools that I'm going to present, there is the inclusion of screening specific to depression and substance abuse. And I note that for the practices that are here from Oregon, because again, depression and expert screening for adolescents is something that is a focus of the 2015 CCO incentive metrics. So the tools that we're going to share for you today are, one, a global tool that was developed by the Children's Clinic that RJ is going to go through. There's also a pre-visit encounter form that Bright Futures developed. It's a really helpful one-page tool that practices can use. And then Kristen's going to be sharing her well visit form. So these are 3 tools that you can access that kind of take that big, broad well visit and put it into a page. Other tools that we've seen that you might consider are the GAP, the Guide to Adolescent Preventive Services. And then here in Oregon, the Oregon Pediatric Society, with funding from the Oregon Health Authority, Addictions and Mental Health, and Adolescent Health, has developed a START module, which is a training for practices that's specific to adolescent depression screening and specific to adolescent expert screening. And so they've developed a great one page that has the depression and expert screening tools and are actually now training providers and are actually seeking some practices that could be part of a second cohort to get some intensive support on how would they implement depression and expert screening. So there are some great resources for you in terms of some tools. So one of the things we've just learned from our practices that have implemented these broad-based tools is unilaterally every practice that we've worked with to implement these identified adolescents that they were sure were fine. So they were surprised. The second is that for a lot of the practices, they used a tool that went to the parent and used a tool that went to the child, and that was really a helpful strategy to somewhat distract the parent and engage the parent in the topic while the team was completing their survey. And again, as I mentioned, strengths are just as important as risks because there are ways that you're going to be able to identify how that adolescent can build off those strengths. And then as with any completed tool, the workflow is really kind of integral to figure out because while the tool can be incredibly helpful, if you don't build it in a way that's seamless into the office workflow, it's not going to be used in a systematic, standardized way. Okay, I'm going to skip this part because I'm sensitive to time and I want to make sure that we have RJ and Kristen share how they implement these tools in their practice. RJ?
All right, so as Colleen alluded to, we actually have two forms that we use during our adolescent visits, and one of them is an adolescent completed form and then the other is a parent completed form. And one of the things that we've been struggling with in our area is we have a number of these teen heart screen clinics that have popped up that are giving free EKGs to kids and then sending them on to cardiologists if they're abnormal. And so we were seeing tons and tons of false positives going to cardiology through those clinics. So when we talked to our pediatric cardiologists, they actually said that we should be asking the parents of teenagers a set of questions, and the screener is unfortunately called the Pediatric Sudden Cardiac Death Risk Assessment Form, which doesn't have a great acronym, but at any rate, we implemented that as a page-long screener along with, and then we added some other questions in just about family functioning and what is best about their adolescent and what is most challenging about their adolescent, so that the parents are actually completing another questionnaire while the adolescent is completing theirs. So the big point is that the parents aren't hovering over their adolescent seeing what they're answering because the parents have their own homework that they have to do. We originally used a tool that was built by the Oregon Medical Association that was based on gaps, but we wanted to get to a more strength-based approach, and that's why we kind of redeveloped the form that we're using currently. And then we put in some forms into our electronic medical records so that we can document the results of the specific screening tools, because within our tool we have embedded the PHQ-2, which is a pre-screener for depression, and then the CRAFT, which is a screener for adolescent substance abuse. So this is the first page of our tool, just to kind of give you an overview, and I'm going to break it out into the different parts. The website link in terms of where you can see the entire thing is there. But the first part is just kind of some open questions. You know, why did you come in? Did you have any concerns that you want to talk about? And then some other things about who's at home, who do you talk to when things aren't going well, and then we talk a little bit about mental health functioning in terms of counseling and so forth. What I found in my visits is that if I don't ask point blank if kids are seeing a psychiatrist, I often don't know about it. And I've had visits that ended with the parent saying his psychiatrist wants him to get some labs for something or another, because mental health is notorious for not sending us any information. So unless we just ask outright, we don't often know. And so I found a lot of value in just asking that right up front. We go through then some questions about school, and then about what they do after school and whether they're working, so we can kind of get an idea of their commitments and their challenges that they might be having in terms of time management. We move then into some health habits about dentists, about whether they're satisfied with the shape of their body, and then some of their health habits about seatbelts, helmets, and sunscreen. The next section is sort of a prompted personal concerns, just so that if kids are not thinking about what they might want to ask, these are some ideas of things that are common amongst teenagers that we might need to talk through. And then getting into the strength-based part, and there are two parts. So there's the 4 wishes. If you had 4 wishes, what would they be? And then is there anything about yourself or your life that you would like to be different? And I found these questions to be very, very revealing about a child's household and the functioning within the house. And so I can very quickly, by looking at the 4 wishes, figure out if it's a kid that I'm worried about or not. If I get a bunch of answers that are like, I want to be in the NFL, I want to fly, I want to have straight A's or whatever, that's completely different from the teenager who answers, I wish my parents weren't fighting so much. I had one yesterday that the child said, I wish my mom could get out of jail and that my sisters could find somewhere to live. And so for me, I honed right in on that part because I knew that there were big, big issues that we needed to talk about. And, you know, that may be something that otherwise might not have been brought up in the visit. The last part of the first page is the PHQ-2 questions that, again, are a pre-screener for depression. And then moving on to the next page, we go in through the craft questions, which are, again, screening for substance abuse. And then we also screen for tobacco use in that, and then also for dating violence. We move from there into sexual health, and then some specific questions both for females and for males, just to kind of get a little more detail about personal health. As I mentioned earlier, we used an Oregon Medical Association form before. It didn't have the standardized screens like the PHQ-2 and the CRAFT in it, and so we wanted to move to something that would have those specific screening tools in it so that it was less of a gestalt and more specific about these are things that we need to hone in on. And as I mentioned, we have 20-minute well visits, and so this form is really what helps us to frame how the visit is going to go. So when I look through that visit, I know what I can skip and what I need to focus in on, and so I can usually identify 2 or 3 big things that we need to talk through, and then the other things, if I have time, I will reinforce them. But you know, I can safely skip some of the parts if the kids are not screening positive for depression, for example. That said, one of the big reasons that we put the strength-based pieces in and then ask some of the other health habits is so we can identify things to reinforce so that we're not just telling a teenager what they shouldn't be doing, but we're also reinforcing the good decisions that they've made. So if their grades are good, we can talk about that. If they're making good choices with safety, we can talk about that. If they have not gotten into a car with somebody who's drunk or high, we can talk about that and what a great decision that is so that we're actually complimenting them, which, you know, if you think about motivational interviewing and sort of the goals there, engaging the individual by sort of pointing out successes and things that they're doing well is one of the I think, primary ways that we gain trust with the teenagers, that it's not just I'm another adult lecturing them on what to do. In order to help ensure patient confidentiality, as I mentioned, the parent forms are being done at the same time, so that pediatric sudden cardiac death risk assessment form. But then also the way we design the forms, we actually printed out on an 11 by 16 piece of paper and then fold it in half, so that if you can imagine that the inside of that folded piece of paper is where the entire questionnaire is, and so it's not, there's nothing on the front that can be seen easily. So when you close the form, nobody can see it. So the parent, again, doesn't have the opportunity to look over the shoulder. And then we put in some decision support to our providers to help ensure follow-up, specifically for the depression part. So I'll show you really quickly the cool programming that my crack team can do in my office. So when we talk through the behavior screen, we have the documentation parts for the PHQ-2 and the CRAFT. Now the PHQ-2, if you have a score of 3 or higher, then it is recommended that you go on to a full screen, and that's the PHQ-9. And so you can see that if the score is 3 or higher, then buttons pop up automatically that we can add in the PHQ-9 form. So we can either print it and have the teenager fill it out, or we can ask the questions ourselves. But that's part of the decision support for the providers to sort of say, okay, if this is where I need to go further and do a secondary screen. So with that, I will pass it back to Kristen.
So a lot of what RJ has said, I will reiterate. I think we have similar practices in a lot of these areas. And I'm just struck by the health assessment or this form is really the brunt of a wellness visit. I mean, the physical exam takes, I don't know, a couple minutes. This is it. This is the key to me, a wellness visit in an adolescent. The other things that we do at times, because we identify how important this part of the exam is, sometimes we may not do the visit at that time, but we may just, you know, if I need to get to know a kid, let's say they come in for a depression screening and they may have had a wellness visit from somebody else. The way I get to know this kid is through this tool, through this form that it just is so comprehensive for me. It really, really quickly hits at their agenda, and then I can look at my agenda. Like my agenda might be that they marked yes to wanting to kill themselves, even though their agenda might be they came in for birth control. So I think it really does narrow down that visit into something that's more meaningful for the client and for the provider. One of the things that we are linked to is EPIC, and EPIC and some of the other school-based health centers are the same. We're related to OCHIN, and we have very little control over our computer, our tools in the computer, so that can be a hindrance for us at times. So we've had to do some workarounds around what we can do and can't do in EPIC. So we have a written annual questionnaire. It's been updated about probably 5 or 6 times in the last 6 years I've been in this role. We have 2 different ones. We have one for the younger adolescent and older adolescent. We really tried to have one. It just felt like the way we were asking questions, and sometimes even what we were asking is different for the younger adolescent. So we have a 6th through, and we go by grades because we work in schools, not ages. So we have a 6th through 8th grade health assessment, and then we have a 9th through 12th grade assessment. And we actually got some funding a number of years ago with the state to really work with EPIC and bring Bright Futures into EPIC. So we have created a tool in EPIC that's based on Bright Futures. So what we did is we created the form that was consistent with the EPIC tool. I am a huge proponent of risks and strengths. I think the evidence around identifying strengths in kids or kids that lack strengths, and we need to link them to strengths, is so compelling that to just do a risk-based model is missing the boat as far as how you can build up these kids to be productive citizens. So I'm really about building strengths as well. So we have that in our tool. We also have a separate form for parent input. The 2 safety questions that I go straight to because I know this is something I'm going to have to deal with today and now, and I can't have them come back, is the suicide risk question, and then we have an abuse question as well. We also, within our written tool, have the pre-screening tools, the PHQ-2, and then the pre-craft, which is 3 questions. And then from there, if it's positive, then we go into the PHQ-9 or the craft as well. The PHQ-9 is built into our EPIC. The craft isn't, but in the next couple of months, and this CCO metric has really pushed it, that we're going to have a really great tool in EPIC that's going to go ahead and combine the PHQ-9 and the craft in it's a reportable way to pull this data off, and also it's all built in, so we'll be able to see it. Right now, the craft is scanned into our form. The other thing that we built is we built something called an episode in EPIC, and if you're not in EPIC, it doesn't mean anything, but what it is it's an episode that we've pulled all the really critical preventive measures into one way to look at it, when their last well child was, when their last chlamydia was, if that's indicated, if the obesity is on the problem list, if they've had lipids done. So we've been able to really combine all of that into one way of looking at it in the morning, and so we're not clicking through the charts. And we also have the health assessment built. I'm going to have you go to the next one. Next slide. So we built it based on the Bright Futures categories, because one of the things that we needed to do, part of it is we have to report back to the state, is the categories that Bright Futures are broken down into. We broke our questions into those Bright Futures categories, and then we have a way of clicking them in our EPIC. And then we have the forms that match based on the age-appropriate questions from 5 to 18-year-olds. So go ahead, go to the next one. And then this is our health assessment. It's 1 page, but it probably should be more. We just kind of had this hang-up that we wanted to be on 1 page, so it's really small font, but it's fine for a kid. It's just harder for those of us that have to review it with a kid. And so as you can see, it's all the different Bright Futures topics. And then at the very bottom is the strengths, asking, who is a caring adult? What is something that you do now that you didn't do a year ago around independence? And one of the other ones I really love is what school, community, employment, or volunteer activity are you involved in? And as somebody that works in the schools, this is a really great one if a kid says nothing, that we can actually link the kids back over into the school, into a fun activity, or get them connected with something, or really work to get them involved in a club. So I think, when you see the positives, it's great, but also, like RJ was saying, if there's nothing there, that's also a red flag. So I really value the strengths part of our workflow, and it's a great way to make a connection with a kid as well. So this is the form that we use, and we use it annually. And then this is for our 9th to 12th graders. Go ahead and go to the next one. And then I was able to get a print screen of our EPIC tool. And what this is, and it's really small and fuzzy, so I apologize, but the green has to do with the categories, and then all the topics are not ones that we cover with every kid. This is anti-historic guidance. So if it's related, then you might click it. But it's also reminding us, oh, yeah, these are really important areas to counsel on or to educate on if it's relevant. And then the other things I wanted to highlight is when you see next to like physical health, the preventive messaging, problem ID, and referral and follow-up, it's kind of hard to see. we have stratified it, and that's one of the things that in Bright Futures they talk about, really trying to stratify where they are in these areas. And instead of doing low, moderate, high risk, we changed it into preventive messaging, a kid that really, you just need to say a few things to kind of support the direction they're already going in, versus problem ID, or then if we're doing a referral. And then there's all this free text that we can also do, and that actually helps us. It gets blown into every single visit. So let's say we've done this for our wellness visit, they come back for a sore throat, we can actually see some of that free text. And the free text to me is where it's at. It reminds me, maybe who they live with, or what class they might be struggling in, or so that we really embed that in our visit. And this is something that we do annually. And I think that's it for me.
Great. Okay, so we wanted to save the last 10 minutes of the session for questions, knowing that we've covered a lot of content and tried really intentionally to make sure any of the key tools that we presented we posted on a website so that you could download them and use them and feel unabashedly. With the request that you share back with us what you learned, because we know that in the world of quality improvement, we all learn from each other in terms of implementation. So Kate, do you want to?
Yeah, so if you can send your questions in through the GoToWebinar control panel. Someone did ask about slides, and again, the slides and a recording will be available. Slides are already on the Institute website, and the recording will be available later today. So a couple of questions came in about minors age 15 and over can consent for immunizations and physical per Oregon law. How do you recommend or seek parent approval if a student or teen consents to their own care and doesn't want a parent to know? And similar questions about parental involvement.
I'll go ahead and take a stab, since I think that frequently we see kids without parents. I'm really challenged by doing a wellness visit without a parent. Part of it is our kids in school-based can go to other providers too, and they may have had a wellness visit someplace else. So I'll see a kid for confidential services. I have a harder time doing wellness visits without the parent at least being aware that we're doing them. And so sometimes for me it's building that relationship with kids. So if a kid comes in the first time, they're super skeptical. It's like, I don't want my parent to know anything. But frequently over time, it's that relationship building around, you know what, they start to trust me, and they trust that I'm not going to share that information. Immunizations, we've had enough angry parent calls around immunizations that we have really a hard time giving kids immunizations without their parents knowing. And sometimes you just gauge it with the kid. If it's a 17-and-a-half kid who's really not even living at home and living on their own, that's very different than a 15-year-old who's living at home and parents are still very involved in their health care. So I think it's something that you have to gauge, and sometimes it's not so black and white, but I think overall we work to engage the parent really, really hard, and I think frequently it's a process, and it doesn't maybe sometimes happen that first visit. It's pretty uncommon for me not to get a parent involved over time, though.
Yeah, and I would agree with that. I think that we've had a lot of challenges with providing confidential services and not having that show up on an explanation of benefits for bills. And so I do a similar sort of process where I kind of gauge where the teenager is coming from and how involved the parents are. I have never given an immunization either without a parent knowing about it. When it comes to other types of screening that might be might threaten a child's confidentiality, I will actually explain to them, here's what could happen. So, how do you want to handle it from here? And, certainly in some cases I will refer teenage girls to Planned Parenthood so that they can get those services completely confidentially. We have had a few experiences where teenagers' parents find out that they're sexually active because of their bill and that we screen them for chlamydia. That's a huge policy issue that we're working on right now, and we actually have managed to get one of the health plans anyway to agree to suppressing certain explanation of benefits to protect confidentiality, but that's an uphill battle. And so I typically would explain to the teenager, if I do these screenings, here's what might happen. How comfortable are you with this, and how much have you revealed to your parents about what's going on? And if they tell me that their parents know, and that they're fine with the risk, then that's one approach. And then otherwise, we'll talk about options for how to get the services in a way that's more confidential and more protective of the teenager.
I just have to say, I have to laugh. I have 19-year-old twin daughters, and my daughter, one of them came home from their visit, and it was really clear some of the screening that they'd had because they were of the age, and it was all totally on their after-visit summary, and it was just laying out there. So I just think, and we just recently had a breach within the health department as well, where and so those of you on EPIC that you do the after-visit summaries, we have to be really careful because we cannot hold back on any of the medications or the labs that are done. And so recently a parent got the after-visit summary and a wellness visit, and I don't know if the client was on birth control or chlamydia testing, but anyway, we just have to be really careful.
Yeah, we're finding the same experience actually as we move on to a portal system that certain problems and medications and so forth, if they show up in a portal, then that's another way of sort of violating the teen's confidentiality, unfortunately. And so we are starting to work through some policies around how long parents can have access to portal and what sort of things they can see through it. We do have a way within our electronic medical record to lock certain visits so that they're flagged as confidential and don't get inadvertently released during release of information kind of situations. But it's definitely, there are a lot of aspects to the confidentiality policy-wise that are tricky to navigate. So.
And again, this is Colleen. I would just note again those policy briefs that I mentioned at the beginning. You know, part of the reason we wanted to distill the summaries and really get kind of broad public-private stakeholder engagement on this issue is because as we were working with these practices on implementing, it was pretty clear that some of the policies and some of the systems were not currently designed necessarily to incentivize the right thing. So the blinding of the explanation of benefits, the issues related to billing for some of the depression and expert screening that you just heard about are all documented in those briefs, and I'm really impressed and feel like there's a good energy that's happening within the Oregon Health Authority and some of our partner leads to start to address that. So if you're interested in being in part of those conversations, feel free to shoot me an email and I'll make sure to engage you in them because I think we have an important avenue of work over the next year.
All right. There was another question about how do you address adolescent risk screening when they don't answer questions honestly, or if you've just found that trust has been built and that they'll share honest things about drug use, sex, or risky behaviors.
For me, I think part of that has to do with it is a long-term trajectory building trust. And so that's part of why we start our conversations about privacy at age 12, and we still do those risk and strength-based assessments at 12 as we're talking about the privacy. So they may not answer completely honestly the first time, but the more times that I offer it, and the more times that I explain the privacy, I think the better the chances are long-term that they're going to reveal those sorts of things to me. I have not, I mean, obviously it's hard to prove, you know, how honestly the kids are answering, but I have it happen enough that they're answering in concerning ways that I know it eventually happens. But I think it is really a long-term trust-building thing, and that's, I guess, one of the advantages of being in private practice is building that long-term relationship, and keeping in mind that a lot of these 12-year-olds I've known since birth, and so you know, they really have come to know me and understand that I have their best interest at heart, I hope. But we just do the best we can and try to bank on having a long-term relationship with them that's going to make them comfortable sharing stuff with us that they need to get help for.
Yeah, I agree. I just think it's all about trust and really always being present as a provider in that visit, because you never know when you're going to make a difference for them. And I also am struck by the honesty in these forms, and I've definitely seen the research where kids are, or I don't know if adults too, but I know in the evidence I've read about youth are more forthcoming in written forms than they are in asking the question. So I think over time you get, I mean, my experience is, I mean, sometimes I've never met the kid and I see this hugely positive health assessment. I'm like, oh my gosh. So I'm struck with just the opposite, how honest and how trusting kids are early on.
Yeah, and I think if you're not using, and I agree the written form is much more revealing, but I think that that the other technique that I have used when I haven't had the written forms completed would be to do the best I can normalizing the experience and then kind of starting broad and narrowing in. So, for example, have you seen anybody in your school using drugs or drinking? And then, well, how about any of your friends? Have any of your friends done that? And so, if you kind of narrow it in, sometimes it makes it feel less like, hey, you using drugs? It's not quite as pointed and aggressive, I think. And sort of saying, okay, I know that's probably going on in your school. Well, how about in your friend circle? And then, well, how about you? And sometimes that's a little bit easier of a way to get at those issues. So I think if you can't use a written tool, which I would strongly recommend using a written tool, but if you can't, then that kind of starting broad and then narrowing in sometimes helps.
Agreed.
Great. So there are a few other questions, but we are right at 9 o'clock. So I told those folks that I would follow up with them via email, and I will do that. There's a last slide here with some contact information, and then there is a post-webinar survey. If you could please complete that. Colleen, RJ, Kristen, anything else that you would like to say before we conclude the webinar?
No, thank you so much for the opportunity to share the great work that's happening in practices and the learnings we gathered.
Thank you.
Great. All right, thanks everybody. Have a good day.
Thanks. Bye-bye.